Welcome everyone. Thanks for coming. We have a smaller group this evening, so I'm hopeful that we can almost make it a round table and have a discussion. So feel free to speak up. Tonight's the first talk of a 5-week series. As some of you know, I believe you've been to other talks before. This is our 4th year, so I figured it out. Anybody who's been here all 4 sessions is a senior. This is our MedEd series. So tonight's talk is titled The Opioid Epidemic and Alternative Approaches to Pain Management. The format, again, will maintain some informal dialogue, but typically it's 7 to 8:30 is our time. So we usually do the presentation first and then question and answer. Always want to thank the Darien Library for hosting us. They host us through the whole series. This is a collaborative between Stamford Hospital, Physician Relations, and the library. My name is Josh Herbert. I'm the program director. I've been with Stamford Hospital for 18 years now. I'm part of the medical group and former president of the medical staff at Stamford. So it's my privilege to introduce Dr. Ofer Wellisch. He received his undergraduate degree at Union College, master's degree in public health from the George Washington University, and medical degree from the Sackler School of Medicine. So after medical school, Dr. Wellisch completed an internship year in surgery at Mount Sinai Beth Israel, New York, then went on to complete his residency in anesthesiology at Maimonides Medical Center in Brooklyn. Next, completed a fellowship in pain medicine in the Department of Anesthesiology, perioperative and pain medicine at Stanford University School of Medicine. Continued on at Stanford for another year, doing a postdoctorate research fellowship. Officially completed training in 2014. Board certified, this is my favorite, board certified with the American Board of Anesthesiology, board certified with the American Board of Pain Medicine, and also the American Board of Addiction Medicine. Came to Stanford this year, assumed current role as Director of Pain Management at Stamford Health, and as with most of our speakers, has been nominated both regionally and nationally as a top doc. Also has extensive research and publications in the field of pain management. So, welcome, Dr. Wellisch.
Totally humbled by that introduction. Thank you. So I'm glad that we have a sort of a small group. Let's keep it informal. You guys could raise your hand at any point, ask me any questions that might come to mind, and I think that would be great. Okay. I guess everybody else is either abusing opioids right now or is in too much pain to show up. So that must be the problem. So I have no conflicts of interest as they pertain to this presentation. This is the opiate plant, the opium plant, right? And so that right there is some sap that you can derive or take from the immature plant. This is an immature young plant, and there's slits on it, and you have the sap coming out. And from that sap, you can derive morphine, opium. At that point, that plant has narcotic potential, okay? As it dries up and matures, it makes some of that poppy seed that we know in our bagels, right? It's no longer narcotic, and that's how that it matures to more dry poppy seeds. Okay. Over the years, we stopped using that sap and the morphine and opium for pain management like we did thousands of years ago. Right. Now we've gotten really good at chemistry, and we have really good pharmaceutical companies. We've created not opiates, which are natural compounds. We have opioids, which are like opiates, but are really good. They last longer, they're more potent, right? They're in the form of pills, right? And they're marketed, patented drugs and so forth. And so in this country, we often get them for dental procedures, for back pain, for post-op pain, and so forth. Where do opioids work, right? So opioids work on our spinal cords and in our brains, okay? And they kind of tell us that it's okay, you're not really feeling the pain. They work on the perception of pain, right? How we perceive the pain. We might be sensing it still in our nerve endings, but we don't really care about it anymore. right? That's what morphine does. That's what opioids do, okay? At the same time, they also cause a lot of dopamine release, right? They make us feel really good, right? Which is what happens when we eat chocolate or when we do things we like to do, right? And when we do things we like to do, what do we want to do? We want to keep doing those things, right? Because we get that release, that dopamine release, that euphoria, we call it, right? And so the problem is that opioids give us good pain control, at least for a while, short term, until we get tolerant to them, right? But they also give us euphoria, and so we really like that. And that can make us very dependent on it. And some people are at high risk for dependence, and some are not so high risk, okay? And so what are some of the effects of opioids on your systems in your body, right? So what are some of the things that can happen when you take too many opioids? Constipation, your breathing slows down, right? If you inject opioids, your blood vessels can collapse. You might inject needles that may be dirty, right? That can give you pericarditis or endocarditis, actually. You might get hepatitis. Your immune system, when you take opioids, even pills, when you take high opioids in the hospital around the time of surgery, your immune system can actually be suppressed, okay? We know this because we've done some of the science behind this. And so we should be very careful when it comes to the use of opioids. My interest actually is in the way that opioids affect cancer cells. And in fact, we've recently found that opioids actually make some cancer cells grow more. Okay?
Oh my.
Yeah. That was my reaction when I heard about that. And so I chose that to be one of my areas of interest, actually. And so we use some of the medications that block opioids in the gut for constipation that's associated with opioids for people that have cancer and need opioids for pain. So we block the opioids from the cancer cells. So we no longer just want to give people just opioids for pain. We want to make sure we use them correctly and responsibly. Okay? And so over the years, when I grew up, not so long ago, we had a truck come by and there was music and it was an ice cream truck. And so now that's been almost replaced by the opioid truck, right? I mean, we have a lot of opioids in our society. We hear about it on 60 Minutes. We hear about it in Time Magazine. Our friends are talking about it. It's been a huge economic burden, okay, to our country. Even Goldman Sachs is talking about that. There's an article in the New York Times that's picked up. There's a guy in Princeton, a Nobel laureate actually, I believe, an economist, Alan Kruger. He's actually noted that a big part of our society that should be working is not. And that's affecting our society, okay? Our economy. And that's a big deal, okay? And so how many prescriptions a day do we fill in this country for opioids? 650,000, okay? So we have, 300, 400 million people in this country. We have almost 500,000 a day filling prescriptions, okay? About 4,000 people start using opioids for non-medical reasons. And about 100 people this past year, actually no longer 78, 104 people on average now die a day from opioids, okay? This is 2014 data. So are we getting better when it comes to dealing with this? Not yet, okay? At least we don't see that in terms of statistics. We don't know until we have numbers starting to trend down that we've actually reached the peak of this crisis, right? So this is in red, the states, the counties in red are the ones that had the most deaths associated with opioids. Our map is getting much redder from 2003 to 2014, okay? People are dying everywhere, all around this country, okay? And just to put it in perspective, it was 20,000 people several years ago. It was 30,000, I think, 2 or 3 years ago, and now it's 59 last year, 1,000 people. And that's around the same number that die of nephrosis. That means kidney failure in this country. That's the numbers that we're talking about at this point. It surpassed homicides, suicides, accidents. Okay? And so there's probably a good reason for that, right? It didn't just happen. We actually prescribed a lot of medications to people. We may have been ill-advised at some point, okay? The medical community was telling us that this is the right thing to do. In fact, about 15 years ago, people said, well, you need to take care of pain, and you need to make sure that you control people's pain better. In fact, some governing body said we need to make pain the 5th vital sign, alongside temperature, blood pressure. How much pain do you have? 1 out of 10. Is that really a good way to measure your pain? 1 out of 10? Probably not so much, but we were doing that. We're still doing that to an extent. And so we come to the point where at that time we were giving people probably too much medication to just kind of satisfy the numbers. And now we know that that comes at a cost. Okay. This right here in red is the amount of deaths associated with illegal drugs, like heroin, okay? And here in blue are deaths associated with prescription opioids, like Percocet, Vicodin, morphine, right? And so one would say, well, around 2009, 2010, people started doing more drugs, right? Well, is that really true? Or did they begin using drugs that were prescription and then moved on to heroin? Right? Well, we know, okay, this just came out a couple weeks ago. The National Academy of Sciences kind of had a report about, well, how should we take care of pain? Now, if it was not opioids, well, what do we do? Well, physical therapy, integrative approaches, injections of all sorts, pain psychology, cognitive behavioral therapy, all kinds of things that, we may not even be paying for, at this point through our insurance. Through our insurances or Medicaid, okay? So we're catching up on having these resources available to patients. We're trying to build that at Stamford now, okay? To have that larger organization that can cater to you guys for chronic pain at a higher level, okay? And so what this shows you here, the people in black over here, okay? These are all the people that do heroin, okay? A small proportion of that in black here are people that did heroin only. And the larger majority of patients started with doing pills and then moved on to heroin. Well, why did they move on to heroin? Several reasons. One, we started saying, you can't prescribe anymore. You can only prescribe a small amount of opioids. Right? And patients are left saying, well, what do we do? And most of those doctors out there, they just don't have other options. They just don't have other tools. Okay?
They don't have what? I couldn't hear you.
They don't have the tools to help the patients, deal with that pain. So we're struggling with that as a field, but we do know about certain things that work, and places, that are larger can offer different services like psychology, physical therapy, integrative approaches. Okay? We have an integrative center at Stanford, for example, where we do acupuncture, mindfulness. We have a robust, physical therapy offering, gym for patients, those sorts of things, okay? That may not be available in every office in the community, right? So those sorts of things may be required to treat someone that's had pain for 10 to 20 years, right? It can't just be one pill, right? We know that. One pill is not going to solve all your chronic pain problems, right? One injection of steroids is not going to solve all your pain problems, right? So we were kind of naive for a while to think that that was the case, right? And the other reason why they started doing heroin was because some of those pills that we now have, like OxyContin, you can't abuse anymore. You can't crush it up. You can't snort them. You can't inject them anymore. They made it so you can't abuse them. So people are now moving to some of those other substances. And another reason is, these people have gotten medications and now they may get them on the street because they can't get it from the doctors anymore. And the cheaper option is heroin. So the bottom line is, we started out giving someone pills for multiple surgeries or for back pain. We've gone up and up on the dose, and now the patient's left holding the bag. And so the problem is not just opioid epidemic, it's the chronic pain crisis in this country, okay? And about 100 million people, 1 in 3 or 4 people in this country have some sort of chronic pain. You may know someone in your family that has headaches every day or several times a week, right? So when your family might have had, God forbid, a bad accident, or back pain, had multiple surgeries, that's considered chronic pain. Out of work, okay, those sorts of things. Society-wise, it's about half $500 billion burden, okay? And in direct costs, about $100 billion for the federal and state governments, okay? And it reduces the quality of life, right? We all know that. And so, how does chronic pain develop, right? Do you wake up one morning with chronic pain? No. Well, you have some injury or years of kind of wear and tear, right? And then we try to fix it, either through surgery or physical therapy or mindfulness training. And then sometimes you heal. That's what we hope happens most of the times, if we do it right. And sometimes you continue to have pain for a long time. And that's considered chronic pain, if you have pain for more than 3 months or so. That's by definition considered chronic pain, not acute pain, okay? The people in chronic pain may look like this, right? Is she happy? No, she's very unhappy. People in chronic pain tend to be unhappy, right? Why are they unhappy? Let me think of why they're unhappy.
They can't enjoy themselves, they can't enjoy life.
Why not?
Because they're constantly feeling uncomfortable, physically uncomfortable.
Right. So they're dealing with pain constantly. And because of that, what can they not do? They can't do the things that they want to do, like go to work, make a living, feel good about that, right? Get rewards through that, ride the bike with their kids, walk around the block with their kids, those sorts of things. Pick up their baby, those sorts of things that we do, right, on a daily basis, right? And you can't do anymore. And that makes people very uncomfortable and sad and depressed sometimes and anxious, right? And that's what goes along with chronic pain. And a lot of patients have those issues, psychiatric disease, before they even have the pain. And once they get a certain pain, they develop chronic pain at a higher clip. Okay? They're more predisposed to having chronic pain. And so what happens is you get amplified, you get sensitized, kind of like an electric guitar, right? An electric guitar has strings. There's a cable like our spinal cord, right? And there is the amplifier, which is this. It's our brain, right? And there's a button on the amplifier that handles the volume, or what's called reverberate, right? And when you turn that up, the volume is tremendous, and it can be very, very uncomfortable to the ear, right? That's what happens to people that have chronic pain, right? Over time, their brain amplifies the pain, and it becomes more and more painful, okay? And so to think that we could treat that with a pill, one pill, or an injection, that's probably naive. So we have to use a team-based approach, right? We have to use various different people. We have to use sleep specialists, lifestyle specialists, nutritionists, doctors to give you medications of various different types that attack the pain at the brain level, the spinal cord level, peripherally. Occupational therapists to tell you, well, or physical therapists, well, this is what I want you to do every day so you can get stronger, right? So your spine is not stable right now, but we can either give you screws to stabilize you, or we can teach you exercises where we can strengthen your musculature around the spine. We can stabilize you that way, right? And so that's what people did a long time ago. That's still what some people do in other countries, okay? 80% of the opioids in the world are utilized in America, in the United States. Some countries use as much opioid in the whole year as we use in one patient in one day, okay? So we are misguided, okay? And part of that is due to economics. It's a huge business. 650,000 prescriptions a day is $1 billion business, okay? And now we have to unwind it because it's hurting our kids. I just did a talk in New Canaan, and we ran the numbers. I think it was 7 people, men, who in the past year in New Canaan died from opioid-related deaths. 7 people in one small town.
That we know of.
Yeah, that we know of, exactly. So that's reported as an opioid overdose, not at home that you don't know about. These are taxpayers, people with families. That's a big problem. in a nice affluent community. And it happens across demographics, inner city and affluent communities. Okay? Kind of like addiction. Addiction, as we know it as a whole, happens in all traces of life. So other medications we could try, okay, are local anesthetics to numb up the strings of the guitar, the nerve endings, okay. Lyrica and gabapentin, these kind of turn down the volume on the pain by blocking some of the receptors. Cymbalta is an antidepressant that helps us suppress some of the pain, okay. Ketamine is a medication that's been used recreationally for a long time, but also in the operating room for a long time. It's an excellent tool. And Johnson & Johnson is now trying to get this approved for depression. Actually very, very useful in depression. Tylenol and Celebrex. When used in combination, these drugs work really well. You can use small doses of these drugs together, and they work really well. In the operating room and before and after surgery, we utilize these pills together, and they attack the pain at different levels in the brain, spinal cord, peripherally, and we get good results. Patients use less opioid, about half as much actually. That produces less side effects, less constipation, less respiratory depression. They walk around more, they read the paper the next day, and they get out quicker, less pneumonia, and so forth, blood clots. And so this is all evidence-based, meaning people did work on this, science, experimentation, and we like to listen to that. We read those articles and that science, and we tailor our practice according to that, okay? Right now at Stanford, if you get a procedure, we just started this week, actually. It's called a preoperative optimization program. If you get your hernia done at Stanford, you're going to get to see someone before surgery, and if you're at risk to have chronic pain, you come to our office and we'll optimize you so you don't have as much pain around the time of surgery. Isn't that great?
Yes.
It's because we care about the outcome. We care about how you do afterwards, okay? And if you have pain around the time of surgery, you can come see us in the office afterwards. And it's the same team that follows you throughout the process, okay? And so this is our pain center, right? This is actually pictures of our pain center, but it demonstrates what we do. We have some integrative approaches, pain psychology. We have some, we're getting a true pain psychologist in hopefully at some point, but we have some people that do integrative approaches, that have fellowships in integrative medicine, mindfulness training, social workers, and so forth, okay? We have physical therapy offerings, as we mentioned, and our physicians collaborate, okay? So we speak to our primary care doctors, they speak to us, and that's really important. Like we said, around the time of surgery, we utilize different medications, so we do better, and we have better outcomes, right? We use nerve blocks, anti-inflammatories, Tylenol, and so forth, okay? We don't just use opioids, and until about 5 years ago, 5 or 10 years ago, people were just using a button that gave you morphine for various different procedures, such as like knee surgery and hip surgery. And this sort of approach has really improved the outcomes, okay? So hopefully we end up here versus people with chronic pain, okay? And we do that through an approach that's team-oriented around the time of surgery as well. And hopefully you end up like this and not like the other picture where she was kind of sad. So that's kind of what I have for you in terms of the formal presentation. And I'm going to answer any questions that you may have about pain or addiction or opioids.
How do pain psychologists work?
Okay. So it's a very good question. So pain psychologists, what they don't do is they don't tell you that your pain is in your head. Okay. What they do is they try to stress the connection between the mind and the body. Okay. If someone has a lot of anxiety or depression, their amplifier is on high. Okay, so any pain that they may sense in their body is going to be perceived much worse than it really is. And so there's ways to control the anxiety, the mood, those sorts of things, to trick the body to think that it has less pain. And you can learn that, and some people don't necessarily have to see that connection between, you know, the way they feel emotionally and their pain, or how their pain is making them feel. And so if you're, you know, very healthy, you know, mind and body, previous injury, now the injury's made you very depressed, you know, perhaps you need to see someone, not for general psychology, but just to educate you on the process of how you may feel very sad because of your pain, and how to separate the two, those sorts of things. They also have biofeedback, that's a skill that they can teach you. Various different approaches that they have. They're PhDs or psychology doctors. They're doctor level individuals. Right now, we have one or two people in the community that we can send you to. We have someone that's out of state that I send patients to right now, and we're working with someone that's local now to build a relationship. And at some point, we may bring someone in-house to actually see patients in our clinic. That's my hope. Okay?
Is this a curriculum that's catching on in medical schools?
It's a great question. So actually, we spent very little time in medical school learning about pain.
Is that right?
Yeah. In fact, I think it's like several hours. And we really learned about just like the neurobiology and, you know, like the wiring versus how to treat pain. It's, really you need to do a residency and a fellowship to learn these days how to do it. And we're learning now that we need to do a better job. And so now, you know, we are affiliates of the Columbia system, School of Physicians and Surgeons. And so we have all the students rotate through us. And so once a month I give them a talk about pain, and we can talk about cases. That's what we're doing to teach our youngsters. And I had a colleague of mine at Stanford in California where his entire project was to work on the curriculum for the medical school there. And that was about 5 or 6 years ago. So, and at that point, people didn't quite see the importance of it, but I think now we really do. It becomes more and more, it's more and more out there. Patients about a year ago still wanted you to give them more opioids, sort of on a big picture, and then, now you keep hearing patients telling you, oh, please don't give me opioids. It's a huge change from what you hear from the community. Now you have to convince people that it's okay to take a few opioids here and there after surgery. There's so much out there in the lay press.
When you were describing the pre-operation meeting, how do you determine if someone is possibly going to be a candidate for chronic pain?
That's a very good question. So there are some risk factors for people to have more pain after surgery. And then those are the things that we look for. So if someone has chronic pain at baseline, then they are likely to have more of an issue afterwards, and so they get shunted to our clinic. If they're on opioids as outpatients above a certain level, beyond a few pills here and there, we see them, and so we help them manage their pills around the time of surgery, because they'll probably need more. Okay, and if they are sometimes if they have a hard time dealing with certain stressful situations. So that means that they should probably come in and we'll chat about it. And even just a discussion sometimes really goes a long way. Kind of a coaching process.
Right.
So, that helps as well. So hope that answers your question.
I'm also very interested in the role of nutrition in controlling pain.
I'm interested in that too.
Yeah.
And so I'm a believer that nutrition has a lot to do with pain.
You think so?
Yeah. And so, even personally, I mean, I used to have a couple aches and pains here and there, and I was put on this anti-inflammatory diet, and then all of a sudden I felt really good. And my joint pains went away. And so there's some studies out there that demonstrate that certain types of foods that we use or we eat can be very problematic for us. They cause a lot of inflammation in our joints and so forth, and there's a lot of it out there. A lot of these trash type foods out there that we eat. And so, we really need to go back to basics
Yeah.
when it comes to food and eat healthy. There are some people that we can send you to in our community. I work with some people, within our organization. We have some nutritionists, registered dietitians at the Tully Center. They work with our bariatric guys. And then we also have some more holistic nutritionists out there in the community that I work with at Stamford and Westport. And they offer some of those regimens to people that are interested in how their nutrition can affect their pain.
If someone's in recovery,
Recovery? Yeah.
for opioid addiction, let's say, what foods are they encouraged to avoid or to eat?
Yeah. So I wouldn't necessarily say that opioid addiction can be treated with nutrition.
But it will help. No?
What I was more referring to is the chronic pain,
Yes, I see. Yeah.
inflamed
Like a
joints, that
backache,
sort of
yeah,
thing.
yeah.
You can use foods as medication, if you will. There are supplements also that I can sort of orient you to that have been shown to be very beneficial in treating even nerve pain. It's called neuropathic pain. There have been studies on some of these, and so we have some resources in our office that I can give you if you're interested. That some things you can try that are not medications, if you will, right? So there's certainly that, and we're learning more and more about that, I think. Okay? Yeah.
I'd comment as a primary care physician in going back to talking about the pre-surgical experience. If anybody's had surgery years ago, you had to go see your primary care doc, get cleared for surgery, and then you were good to go. And that has changed because our thinking from a primary care point of view was all about preparation for surgery. Never even thought twice about the day after. That was up to the surgeon. And oftentimes, due to the timing, if a patient came in to my office, for example, without much time for clearance, they had already received all of the information from the surgeon and the prescriptions. They'd come in with a prescription for Percocet that hadn't been filled yet, and so there's education for all of us, not just patients, but also each role the physician has. And having this clinic is great because it is helping with all those things that we don't do as physicians, especially for the pre-surgical clearance part, talking about management of pain and really optimizing before and after. We really never gave consideration to the after. But I have seen these prescriptions written by another doctor for huge amounts of Percocet. And I'm talking years, in the past years. This is definitely changing. But again, my point is it has to be uniform. Patients have to understand it, the surgeons, the primary care docs. My concern right now, having 2 teenagers in my house, is the effect of painkillers and medications on students and a developing brain, and a brain that doesn't necessarily think of consequences of actions. And that's another focus of education, which I'm happy to say, and we were talking about right before, my oldest is a freshman this year at Darien High, and it's a requirement now for any student who wants to participate in any sport or any extracurricular activity club, mandatory, I think it was a 3-hour session at the school with a whole panel, including a psychiatrist, a physician talking about pain, a police officer, an attorney, a social worker, each giving their perspective about the dangers. And it was not just medicine, it was alcohol and other potential threats to the young brain. That's where my concern is too, because we also live in a town where there's a lot of athletes and good athletes, and they get hurt. And then the prescription for pain meds. And so it's education for parents as well as the kids to get in front of this, otherwise we chase it for a long time.
Is that common in all Fairfield County public schools?
I don't think so.
I've never heard of it.
I think that in the talk, somebody was commenting about really commending the school, saying this is great,
Right,
it's
right.
great. And it was, sometimes I think we're a little bit cautious with the kids. Not at all. There were videos of accidents, kids dying in the emergency room and showing it, the blood, the CPR, the failed attempt at resuscitation, the family coming in as the kid has just died, the friends there. I mean, it was fine, according to me. I think that it was perfect. The message, that's what the kids see.
Yeah. And I'd be happy to take any one of those youngsters around with me to see some people that are in trouble in the hospital.
There was an addict who spoke too, if that reminded me, a woman who stood at the podium and said, I was you. I was a fortunate kid to grow up in this area. There was another town that's similar. And I smoked a cigarette, I drank some alcohol, then I tried some marijuana, and but that other stuff would never happen to me. And eventually she told her story about becoming an addict and being homeless and being on heroin and almost dying several times and surviving. So I think that was a good message for the kids too, to see a peer. She's only 23 or 24 years old, so not much older than the kids in the audience.
I mean, some really great points there. I mean, one is, the effects of opioids on our brains as adults, which we didn't quite appreciate until recently. And now with brain imaging and what's going on out there, we kind of appreciate it. And then, we still give our pregnant patients opioids all the time, saying that it's safe. And we know it's probably not. Patients that have headaches, plenty of patients with headaches, they get opioids all the time, barbiturates, and they're considered safe. And we just can't prove that they're unsafe, or how the kid does 2-3 years down the line. And same thing with obviously with youngsters, and they might feel that euphoria. So I think that we've come a long way. We've come a very long way. That we not only appreciate that there is a problem, with pregnant women, pediatrics, children being born with addiction, dependence, neonatal abstinence syndrome. Young adults can get hooked after having multiple football accidents or injuries. And then adults that can lose their work, not from just the pain, but also just from being dependent on some of those medications. And so you have to be responsible. And, we no longer give 60 pills, 90 pills, 120 pills for someone that just had a simple procedures or a dental implant. A lot of times that's what you see. Someone had a dental procedure, boom, 30 pills. You may just need to have just a Motrin, In fact, a Motrin can go a long way, particularly if you take it before. Okay, it may work better than opioids afterwards. That's been shown. Because it decreases the pain that you have after the procedure if you take it before. It's actually been shown. You compare one patient that had Motrin before the procedure versus someone that had morphine after the procedure. People that had Motrin before the procedure prevented the pain from even occurring.
Wow.
And they did better than that. Actually, it was actually Toradol and morphine. That was what the review was. Third molar extraction.
Really?
So that was done at NIH, and it was done, early, but we still do this. We still give people these medications. And so now some of the policy out there is to give you only 5 days. That's what the state allows us to do now. If you have surgery, you get 5 days worth of opioids. And if you need more, you come back to the doctor, and the doctor has to reevaluate you. When I was a resident, they told us, hey, give this person a script. They're going home. And I said, well, how many pills do I give them? Yeah, well, they give them 30, 60, 90 pills, whatever. Just make sure they don't call us. So, it's actually like I didn't quite have an understanding of how big of a question that was. Well, how many pills did we give them? But we actually looked at that when I was in California, and someone looked to see, well, who is the patient that needs to get more than 2 days of pills? One patient takes 2 pills and stops and takes Motrin, and the other one calls you in a month, wants a refill, and then the following month wants another refill. Same procedure, same age, right? And it's just, people are different. One has depression and anxiety and is out of work and is coping with the pills instead of, facing some of the issues head on and going to see a psychologist or whatever. Okay? And some patient might be genetically predisposed to having addiction. 15% of our population, is, I guess, addiction, right? Has addiction for problems, right? That's cross demographics. Okay. So it's a big issue, and we're trying to isolate those high risk individuals in some of these programs that we have, and we're taking them through the process. And it's not just pain. You know, it might be that we have specialists that do the same thing for respiratory diseases or diabetes or some of these other things that people are really good at doing around the time of surgery in the hospital, and they kind of shepherd you along. Whereas before we really weren't thinking about that, that time, around the time of surgery. That's very acute.
So and I've used some of them, the alternative modalities for pain management, and really some of it's almost, if you combine them, say for example, physical therapy and nutrition and whatever, it can take up so much time that you could spend your whole life, days trying to deal with pain and these different things. So it's a problem for a lot of people who need to function and just to get out there and do whatever without spending their whole life trying to deal with pain. And
so the idea is to make you more functional.
Yeah.
So a lot of times I ask patients, well, I'm not really interested in the number from 0 to 10, but since we did this procedure, or since I put you on this medication, are you doing more? Are you able to go to the supermarket and do what you do on a daily basis? And if you are, then that's great. You don't have to do physical therapy forever. I tell people go physical therapy 6, 12 times and then learn what to do on a daily basis so you can assimilate that into your lifestyle. The idea is to get you back to what you want to do. Initially when you have pain, we want to assess how it's affecting your life, how it's bothering you, all right? Why are you disabled, why are you debilitated, and then try to fix that, not make this like a burden on you. That's really the focus. The other thing I want to chat about is, if you have pills at home, so you don't want those other teenagers to be able to get those pills, right, and utilize them for recreational purposes, right? Some people might be of age to make ill-advised decisions, right? So we have programs where you can take that to somewhere where it can be discarded safely. They have take-back programs several times a year around town. And then in the police stations, most towns have these bins where you can bring those medications anonymously, any narcotic or any medication, and just dispose of them in that bin. Okay, no questions asked.
Darien does.
one of the issues that I also have a degree in public health and in nursing, is when you carry a prescription, you're supposed to carry it in the original bottle from the pharmacy. And people who have a variety of pills or controlled substances in their bag, they may have all sorts of things. And that always bothered me, to have them labeled with the prescription in there, carrying a bottle of every, so many things. And was wondering if it could make sense somehow and would be legally covered, like if you were stopped by the police, to have in your wallet a card with what you're medically prescribed, or even if the doctor initials it or something, so that they don't have to carry a bunch of bottles with this if their bag is stolen, especially like I work up in the inner city in New Haven, and there's robberies and purse snatches, that you don't have, okay, this controlled substance and that one and this one, all there. So I don't know what the answer is, but
your concern is that you have to people have to carry their pills around?
Yeah, they do. You have to carry your pills around in the bottle that comes from the pharmacy.
Right, but
Labeled.
When you have a prescription for opioids or
Anything.
benzodiazepines or whatever it is that's controlled, really anything, you should keep them in a safe environment. And with controlled substances, you need to have them locked up, actually.
No, I'm talking about carrying your bag. If
Yes,
you need to carry...
You shouldn't keep them in your bag, you should keep them locked up. And
Where you
not your
keep them?
daily supply, obviously. If you have to go to the supermarket and you're going to need to dose yourself, you can take it with you.
No, but people are going to work, people are doing whatever, you know what I'm saying? Or in their briefcase or
So you
something.
should not have like a month worth of
No, not a
prescriptions
month.
on you, because that could make you be a big risk for...
Right, but if you have, say, for example, a person or a patient has several pills that they carry, and each bottle takes up space, and they may only put a little bit in it, but I just don't think that's really advisable. I would like to see somehow they could put things together in one little pill box, which you're
Yeah.
not supposed to carry, and then have a card, an identification card of what's in them. But
Yeah.
you're not allowed to put your pills in that unmarked container.
Yeah, that's the problem, because then you can make a mistake and take the wrong pills, right? That could be a
Well,
problem.
that's possible, unless,
Yeah.
well, now with the generics, it's more probable than
Yeah.
when things were more identified, you know.
So that's a problem. I mean, I've heard of people taking Ambien instead of like aspirin or something like that.
Well, they could if
Yeah.
they do, you know.
Yeah.
But I'm not talking about the
Yeah.
patient, I'm talking about more in terms of, because I've had purse snatches, I've had, you know, all sorts of things in the inner city.
Yeah,
And, you know,
Yeah.
what would be in there, so.
yeah, it's a problem. You know, the problem with opioids, one of them is that it makes you a target.
Yeah,
It makes you a
well,
target.
if you have it, yeah.
Yeah. Like
No, I
people that have elderly people that have opioids in their house.
Right,
Once they pass away, sometimes people go rob their homes just for the opioids.
yes, it could, yeah,
Those sorts of things, you know, that they do happen.
that's terrible, yeah.
So every year, we have an annual meeting with legislators and trying to look at some of the loopholes around opioids. Like this year, we got passed where somebody who doesn't want to have opioids can have that on their file, things like that. We piloted the medication drop boxes. So it was interesting listening, so maybe after I'll get your information, because we meet with the legislators and they're always looking at things that could be potential ways that would, you know, increase access. And if there's some kind of regulations that we're always concerned that don't, you know, that don't cause too much havoc with the whole system or anything like
Right.
that. But this could be something to make people aware of, because I didn't know
Yeah.
that that was a law.
And you know, if you don't
Well, you have
have
to have the prescriptions, and even things that are not opioids, or, you know, any prescription has to be in the original bottle from the
I
pharmacy.
see.
So if you're carrying just a few, the idea would be ask the pharmacist to print out another label and give you an empty bottle, so you can put like 2 of them in there
Yeah.
instead of like having to carry the whole
yeah, so
thing.
sometimes they, you know, for elderly people, for example, they have like, they make
The little packs.
like packs, yeah,
Yes.
like blister
And that's
packs.
something that we're working on to get opioids mandated.
Yeah, just not opioids, but any prescription,
Right.
you know.
Yeah.
And you see an old person
Yeah.
carrying around 15
Yeah.
different drugs, you know.
Yeah.
Yeah, I don't know,
Yeah.
yeah.
And you know, like if you don't have a pain doctor, I think you need to talk to your primary care doctor about some of these issues that you may be, you know, experiencing or fearing, those sorts of things.
Yeah.
You know, they're going to be your advocate. You know,
Well,
and kind of
fortunately-
navigate the
yeah.
system.
Yeah, fortunately for me, I was in pain management, must have been 20 years ago, and thank God I had a wonderful pain management specialist and really took care of it for, you know, but at the time it was horrible, you know? Yeah.
What about alternate, you know, pain management, like prednisone shots or oral prednisone? Are those,
Yeah.
like, I mean, I know those are also frequently done, those
Yeah.
injections are frequently done. Are
Yeah.
those dangerous in the wrong sort of, you know, hip socket, for example, in a healthy hip socket? Can it be dangerous? Because I have a D1 athlete actually, and, you know, that's been offered
Yeah.
for pain.
So steroids are really powerful tools for dealing with inflammation, right? So, you know, we use them all the time for like the really bad chronic diseases like lupus and rheumatoid arthritis, those sorts of things. We also can use them either by mouth or through an injection locally at areas where we have inflammation. So if someone has like a bad knee, you know, tendonitis, or, you know, partially torn ligament or whatever, you know, we can inject some steroid locally so they get less of a systemic effect, although they do get some systemic effects, you know, and that could be very, very helpful, you know, to people. Now, we can't do that every day. We can't do it every week. We can do it several times a year. If you do it, you know, 5 times a year, 10 years straight, then you could seriously have consequences to steroids. There's no question about that. So we have to use every one of our tools, you know, appropriately and responsibly. And you know, I say that there's several pillars to the pain management that we practice, and you know, one pillar is management of medications. And that's non-opioids, nerve pain pills, opioids, et cetera, et cetera. There's a pillar, it's including injections and, spinal cord stimulators or TENS units, those sorts of things. We have physical therapy, integrative medicine, pain psychology, and we should use all of those tools to, really achieve wellness, right? If you just do one of them, that's going to be fraught with some adverse events or adverse effects most likely if you overdo it. Okay. So in some patients, like if you're just a weekend warrior and you hurt your knee and you do a single injection, it's gone. Great.
Wow.
I love that when that happens. But with chronic pain, sometimes it's not that easy. I'm sorry, Ingrid, did you want to say something?
Is acupuncture part of your?
Yeah, that's certainly an integrative approach kind of basket, and we have people in our organization that are certified, and they do that, and there's some really interesting data there. That the act of doing the acupuncture, whether you believe in it or not, there's even the placebo effect is very profound, and there's a lot of stuff that goes on in your head when needles are involved. Right?
Yeah, I saw Dr. Brodsky there, and it was so helpful. He did just one point.
Yeah.
It wasn't acupuncture. I wanted it, but my insurance doesn't cover. So
Right.
I just had one needle points, and it was very effective for the spasm and what. And that's an occasional thing after things act up a little bit.
So I think that I feel strongly about using those type of approaches instead of using some of those really bad medications and those sorts of things. So I encourage you to try things like that. What I want to make sure that I do impress on you is that those types of things are passive, and so you can have back pain, go see someone for acupuncture, and they'll do some needling, and then you leave, and then a week later you have the same problem again. Right? So what I prefer that you do while you do that is also do physical therapy and have them educate you on how to do stretching and strengthening and those sorts of things, so you don't end up in the same problem. And those are active approaches. So we'd like to kind of help you facilitate that for you.
25 years later, after my severe injury, I'm hiking now. So.
Excellent.
Going these hikes, so I'm okay.
Taking all those bottles with you? All those pill bottles with you?
No,
Very heavy.
water
Very heavy.
bottles, the water bottles.
Minimize.
Yeah.
Are insurance companies supporting all these alternate methodologies?
That is a great question. So I alluded to the National Academies of Sciences and Arts and Medicine, I guess. Used to be called the Institute of Medicine, and now it's National Academies. They just released this report that had a bunch of experts that told you about these various different things that may work for pain. And we have pretty good data that if you do that, you get good outcomes. But yet we haven't caught up yet. We really haven't caught up yet. So some areas in this country have caught on faster. Some payers, workers' comp or different commercial payers, insurances have caught on, and some have not. And so I think it's going to be a process.
If opioid addiction is designated as an epidemic, will that be a push towards insurance companies?
So as far as I know, the Affordable Care Act, made it so you can't deny people behavioral therapy, right? So I think that applies to pain psychology too, okay? The problem is that we don't have a lot of providers that will see patients for like psychiatry and psychology with insurance. They like to have you pay for privately, That's a big problem, I think, in this area and in a lot of areas. We also have those services for people that don't have insurance at all. I have a pamphlet in my office that has about, 200 places that offer really good counseling for free. That's offered from the state. They kind of put together this resource. And I think there's also a number called 211, right? Which you can call and you can get, directed to behavioral health resources. So there's actually a lot out there. We need to be better at actually triaging patients to those places. And you'd be surprised that some of those places that are for people that don't have insurance actually do a great job because they actually coordinate really, really well. So I would talk to the primary care doctor that you have to kind of orient you as to where you can go with your insurance. And they know people, they tend to know people, okay? So in terms of like psychology, it is out there. Physical therapy, at Stanford is pretty much covered, for pretty much everyone. Our services, as a pain center, offered to everybody. We see all insurances pretty much, as far as I understand. We see, the Medicaid population. Probably see people with no insurance at all, actually. So, we want to take care of the community, and we see patients that have private insurance, that sort of thing, and people that pay cash. So we see everybody, and we offer, I think, a very high level of service. And we're trying to get some of these other services in-house. So in reality, I think that some of those things we spoke about, we can offer it to pretty much the entire community at this point. Yeah, that's what we're trying to build. Yeah. All right. Good.
One other question. I saw you had Lyrica up there. How does that work?
So that's a good question. I'm not sure we know exactly how it works, but what it probably does is it binds to this thing called the calcium channel, and it makes it so it doesn't form properly. So the calcium channel doesn't work. And so what happens is when the nerve fires, it's called an action potential, when the nerve fires, it doesn't quite fire properly. And
So it doesn't transmit the pain.
doesn't transmit the pain as well. And so it turns down the volume on the pain.
Okay.
And so people that have numbness and tingling, pain down the legs, neuropathy, trigeminal neuralgia, patient with pain in the face, those sorts of things, if they get to the right dose, sometimes the Lyrica can be very effective for something like that.
Is
Fibromyalgia.
Is that an SSRI Lyrica? Or
It's not.
Cymbalta might it be?
It's not. It's its
No.
oit's own class. It's called the gabapentinoid.
Oh, okay, okay.
Very similar to gabapentin.
Right.
It's absorbed better. Yeah, it's a different class of medication. It's a nerve pain pill. Okay? Yeah. And when you see your physician, you should always ask them, well, what does this medication do? And they could have a sort of a discussion with you about, the risks and benefits.
Yeah, we have some patients on it, because I work at the post-traumatic stress center, and I think some patients are on it, but I think it's more where they didn't put it on. They came with the Lyrica, but maybe would it be used for fibromyalgia?
Yeah, it's actually FDA approved for fibromyalgia.
Okay.
And why? How does a drug get FDA approval for fibromyalgia? Because it actually showed that it's beneficial.
Okay.
So, how many patients have I seen that actually get opioids for fibromyalgia? A lot. Is there any data to support using opioids in fibromyalgia? Not that I've seen. So, in fact, just so you know, it's important to say this, no one's ever looked at opioids for more than, I think, 6 months to a year.
Really?
Ever. For safety or efficacy. So, what we have seen is that after 15 or 16 weeks, it's pretty much not any better than a sugar pill. That's hard to believe, but it's true. Unless you go up on the dose.
Or you take them, daily, but if you just take them PRN for when there's acute pain, did they look for a long
That's
time?
right. So if you don't take them regularly, you don't get used to them, and then you can use them when you need them. That's the way you're supposed to use them, right? But if you keep using them, they tell you take it 3 times a day as needed. And if you interpret that as take it every 3 times a day, every day, then after 4 weeks, you no longer get any benefit. It's just like you get used to it, and then you need to get a higher dose, and otherwise you don't get any benefit at all. And then when you stop taking it, all of a sudden you can't even be normal anymore. So that's how addiction works, and dependence. Dependence and addiction are different. You're not necessarily dependent. Not necessarily addicted when you're dependent on a medication. What dependent means that when you stop taking it, you have withdrawal symptoms. Okay, And addiction means that you just can't stop even if you try. And you know it's bad for you, okay? The thing with opioids is after a while, some people have a problem. You know, they treat their anxiety and their depression and their pain, and that makes them feel good. And then after a while, they need it just to feel normal. And that's dependence. And so it's good to use it here and there at the right point. There is a good way to use them, but it's important to educate patients on how to use them and not to overprescribe. Okay? Very easy to say, hey, here you go. Hi, Mrs. Smith. How's your pain? Here's another script for another 30 pills, and see you next month. That's kind of it's an easy visit, right? So we don't want that to happen. We want to make sure we have a larger conversation about, well, what are we doing? I mean, what is this effective? You want to go down on the dose, up in the dose for a little while, maybe come off, and then come back on if you need. Maybe like a holiday, called an opioid holiday. And so, if anybody has a problem with opioids, there are certainly things we can do. Okay. I realize maybe we didn't touch on that so much, but there are some very good programs to help with opioid addiction and dependence. There's medication we can use for that. There's counseling that we have, either in our organization or other places in the community that have peer groups and psychologists and so forth. There is definitely help. So if you know anybody, have them seek help. Primary care doctor, see an addiction specialist. There are some bigger organizations like Mountainside or Silver Hill that offer inpatient and outpatient services. There are services out there. Okay. The problem is that most of the funding is going to fund Narcan, which is like the pill, what you give patients when they overdose, and those sorts of things, versus preventing the dependency and treating pain. Those two big issues, as and preventing versus treating later on with the consequences. So I think that we need to talk to representatives, talk to people that will make a difference about appropriating those funds to organizations that can positively affect their wellness and their health early on in the process. And those are really encouraging stories about what's going on here in the high schools. It sounds like a great program, and we should have more of that, that kind of thing. So.
This may not be in your area, but is there new research to indicate that stimulant medication is overprescribed for ADD, for example, in kids? I'm thinking especially.
Yeah, that's a little bit out of my area of specialty.
And I'm wondering too if they are. Is the stimulant medication a gateway, to obviously?
Yeah.
More addictive.
Yeah. So look, I mean, what I can say is that some of those stimulant medications are FDA approved for ADD, right? And when used appropriately and responsibly, probably that's fine. What's not fine, for example, and I see it all the time, is I give someone a lot of opioids, and so they can hardly stay awake. And so they give them like Adderall or a stimulant so they can wake up in the morning. And so that actually happens a lot more often than you think.
Is that right?
Yeah. And so that's the kind of thing that maybe is not as appropriate. Sometimes in elderly people we like to give them a little stimulant just to increase their function. There are various ways that are very appropriate to use stimulants, but like anything else, do it in moderation and appropriately, and it's about how good of a doctor you see. Not all doctors are made equal, created equal, I guess. Dr. Herbert can probably attest to that. So that relationship, I think, is.
I think it's when you look at the statistics, though, and I think this might be what you're alluding to. When you take, for example, the United States, and you look to see where there are more diagnoses of ADD and those areas where kids might be medicated to you will see it in certain towns and not see it in others. So why is that? Why is it that a town, again, like Darien, is going to have a higher number? And I think the answer is because people look for it. And whether, you can put a lot of variables into it, but you do see it. And when that happens, there's abuse potential. And if you ask any kid if they can get Adderall around exam time, the answer is sure.
Yeah.
No problem.
Yeah, the other thing, obviously, that's such a hot item is anxiety in especially adolescents, and, the result of migraines and stomach issues and
Yeah. That-
suicide.
Interesting the way you kind of mentioned all those different symptoms, and a lot of times kids, will say, I have a bellyache, right? And
Right.
we know that when a kid says I have a bellyache, well, we ask them, well, what's going on? How's school today? Everything going on? Everything okay? And why is that? Because kids tend to somatize their pain. It's easier for them to express their pain as a physical complaint, like pain, versus an emotional problem. A lot of times, we do that. Even adults, we say, it's easier for us to say we have abdominal pain or stomach pain than, we're feeling very cruddy and sad, okay? And a lot of times, so we see patients that have pain like that. It's very difficult to explain. And we try to look for reasons why they have pain and we can't find them. And we treat them for pain with medications that we might be helping them cope with their problems, whether it's opioids or marijuana, those sorts of things. And some things like marijuana are, can be very useful for anxiety and depression in the short term. And then maybe even help you with some of the stomach problems initially. But then after a while, they cause a lot more stomach problems, vomiting. They cause more anxiety, particularly if you had it in the beginning, more depression. Okay, so it's actually not such a good way. Same thing with opioids. It's a good way in the beginning to cope, but then over time, a very poor way. Mm-hmm. And actually, we have some early data from Colorado, which is, you may know, a place where, it's become very liberal to use marijuana, for example, recreationally. Mm-hmm. We can use marijuana in Colorado. And they found that, this is published recently, maybe I think it was a week ago, in a gastrointestinal journal, like a medical journal, mm-hmm. That we have a higher rate now of what's called hyperemesis syndrome, or cyclical vomiting syndrome, which is basically is when when kids or young adults mostly have these episodes of they just keep vomiting and we can't explain it. They can't really take any food and they end up in the hospital and so forth. And that has been thought to happen with overuse of marijuana.
Wow.
But we couldn't really prove that, and we still can't prove it. But we know that in Colorado there's a big spike in it right now. So I think that's just the first sign of, well, this may not be the best thing for us as a country, is to say that anybody can smoke marijuana at any time, because we're going to have more accidents. We're already seeing that, and more stomach problems and so forth. Things that we know can occur with using like a thing like marijuana inappropriately or overusing it throughout the day. For people ask me, is marijuana good for pain? In this state, we can use it for pain. In certain conditions that are really bad, and I say you don't really want to have those conditions, like cancer, Lou Gehrig's disease, multiple sclerosis, those sorts of things. Chronic back pain, as far as I know, we can't use it yet, right? In New York State, they just changed the law in January. You can use it for chronic pain, any chronic pain. Okay. So, can you smoke marijuana and go work at JP Morgan? Probably not, right? You can't function and do numbers and those sorts of things. So it's by definition not a great medication, kind of like opioids. You can't necessarily take morphine and go working at the bank, right? You can't be a doctor and take opioids in the morning. You might make a mistake, right? It would be catastrophic, right? So, before we let everybody there were bus drivers and so forth, take, marijuana for back pain, I think we have to consider, the consequences. And there's really no good data to support the use of marijuana for pain at all. There's really no good data to support that. In terms of anorexia and helping people to have eating disorders, we have some pretty good data on that, actually, but not really for pain. And so I think it was a big question.
Is it helpful? Is it helpful with anorexia?
Yes, it is. And there's actually a medical pill that you can take. It's called Marinol for that.
Ah.
It's FDA approved for that, anorexia. So, right.
When a doctor prescribes marijuana, they get a pharmacy to give it to them. What form is that in? Is it in the pill or do they smoke this? Or what
It depends on the state. I believe in this state you can get all kinds, all forms.
You can.
Some states are just smokable.
Okay, now when they process it for prescription use, do they take out, was it THC? Is
Yeah, so
that in it or out of it?
yeah, so you can get what's called only CBD.
What's called what?
CBD, which is the cannabidiol or cannabinoid, not the THC, which is the more euphoric substance. And so there's some thought that, if you use one versus the other, one is more medicinal and one is more recreational.
So they would take out THC for
Yeah.
pain, like if you put it in a pill?
Yeah, so we don't have enough research to know what works in marijuana and what doesn't work. And so part of that's because it's been illegal. We haven't had the research. But nothing's really stood out. When it comes to spasticity, people that have spasticity with multiple sclerosis, then we know that that it may be helpful for. And the CBD, the oils, might be useful for that. Parkinson's, the oils actually have been the marijuana oils can be useful for that.
And they take that orally?
Yes. Yep. But then the smokable part, or the THC, may not be as effective for that. But again, that's something that you might want to ask a physician at that point to kind of orient you to that.
No interest.
Yeah.
I'm just curious.
Yeah. All right. We've covered
Thank you very
a lot of
much.
ground. Yeah.